From anatomy to anesthesiology, from pathology to pharmacology, from microbiology to medicine, a one-man resource to the world of health sciences. Welcome to Dr. Paul's Medical Lectures. A practicing physician, Dr. Paul offers you essential insights on diseases afflicting millions of people around the world. For today's lecture, here is Dr. Paul.
Good afternoon, folks. This is Dr. Paul. Thank you very much for tuning to our channel today. This afternoon, I want to talk a few minutes about acute otitis media. It's the most frequent diagnosis in sick children visiting clinicians' offices in the United States. And many times, the systemic signs and the symptoms of acute otitis media, they usually resolve in 24 to 72 hours with appropriate antibiotics. And somewhat more slowly, if you don't give antibiotics, children sometimes recover because the body has the immunity to fight it off. Now, I want to talk a few minutes about the most common presentations. Many times you treat the ear infection, but children will still have middle ear effusion. That is middle ear effusion. Remember that, folks. Very, very important. Because middle ear effusion, it can cause conductive hearing loss. And the prolonged presence of middle ear fluid may lead to a mistaken diagnosis of AOM in patients with subsequent febrile illness. For example, you treated a patient 2 months ago for ear infection with an antibiotic. The infection has gone. Now, after 2 months, the patient came with fever, probably respiratory syncytial virus fever. You checked his ears and you found fluid, and you thought it's ear infection. You gave an antibiotic. You see what is happening? Sometimes you might treat a sterile fluid, mistaking it as middle ear infection. Now, I want to concentrate in this video only on the treatments. There are treatments. You always need to treat them for pain. There is Aralgon, and that is a combination medication like antipyrin, and also it has benzocaine in it. But topical benzocaine preparation should not be used in children younger than 2 years of age because why? They may cause methemoglobinemia. Remember that. Topical benzocaine, don't use below 2 years because they can cause methemoglobinemia. What about antihistamines and decongestants? There is no evidence they help. You can use Tylenol, ibuprofen. Tylenol and ibuprofen, like 10 milligrams per kilograms, like 3 times a day, you can use it. Cough and cold medications should not be given to infants and children younger than 2 years of age. Remember that, folks. Cough and cold preparations should not be given to children younger than 2 years because of severe life-threatening complications. So you need to be careful when you see these children. You always think about their age. And there is also, you don't have to give antibiotic to every child. For example, if they are less than, like if they are younger than 6 months, always try to use an antibiotic. They are from 6 months to 2 years. If they are looking sick and you are certain of diagnosis, then use an antibiotic. But if you are not certain of diagnosis and if they are not looking that sick, I mean the sickness is not severe, then don't use an antibiotic. But if they are looking, if your diagnosis is certain, and if they are looking severely sick, then use an antibiotic. Now, antimicrobial therapy. The first line therapy is amoxicillin. This remains the drug of choice because it is effective, it is safe, it is relatively inexpensive, and it also has a narrow microbiologic spectrum. So amoxicillin, you double the dose. Like usually we use like 25 to 40. Here you use like 80 milligrams per kilograms because you are increasing the concentration of the medication in the middle ear to fight against the intermediate strains of Streptococcus pneumonia. So you see, you need to increase the concentration of amoxicillin. American Academy of Pediatrics or American Academy of Family Physicians, their guidelines recommend that you use the amoxicillin as a concentration of 80 to 90 milligrams per kilograms, and in fact you can go up to 3 grams a day, because only at those concentrations are Streptococcus pneumonia are responsive to this treatment. So high dose amoxicillin treatment is the key. And there is, there are children, in fact, who are at risk for more resistant bacteria, then certainly you cannot use amoxicillin. So children who are treated with antibiotics in the previous 30 days, particularly beta-lactam antibiotics, or children who has otitis and conjunctivitis, that's purulent conjunctivitis, we call it otitis conjunctivitis syndrome. It is caused by non-typable H. influenza, which is frequently resistant to beta-lactam antibiotics. So for them, you should not use beta-lactam antibiotics. Children who are on chemoprophylaxis with amoxicillin, obviously they are not going to respond to amoxicillin. Children who are on chemoprophylaxis for urinary tract infections, they are not going to respond to amoxicillin. So they probably developed beta-lactam resistance. So you should go for other antibiotics. Now what about penicillin allergy? When patients have penicillin allergy, you can go to other antibiotics. And also think about hypersensitivity. What kind of reaction they are getting? If patient is not having a type 1 reaction like anaphylaxis. So for non-type 1 reactions, you can go for cephalosporins. So ask always, what kind of a reaction you get when you take penicillins. That's the key. For non-type 1, you can use other things like cefpodoxime, there is this cefuroxime and cefixime. All these cephalosporins, they come to your rescue in a patient with penicillin allergy. So start with penicillins first. For penicillin resistance, go for other things. The other treatment nowadays being used is ceftriaxone, 50 mg per kg, like a single injection. A single injection of ceftriaxone, 50 mg per kilogram, is called Rocephin, everywhere available throughout the United States. So you give a single injection of Rocephin, ceftriaxone, 50 mg per kg, and sometimes you observe them for 48 hours. If they are not that good, give one more injection after 48 hours. If they are not good after 48 hours, then give one more. So you see, you start with one ceftriaxone injection. If they are better, that's it. You don't have to do anything. Just follow them closely and make sure they got better. If they are not better, give one more injection after 48 hours and then wait another 48 hours. If they are not better, give one more injection, and so on. So you see, intramuscular injection of cephalosporins, Rocephin, has a role in the treatment of ear infections. Then comes macrolides. We have macrolides like erythromycin plus sulfasalazole, azithromycin, clarithromycin. What about Bactrim? Now, trimethoprim sulfamethoxazole, that is Bactrim, should be used with caution. Why? Because there is a resistant pneumococci. Erythromycin plus sulfamethoxazole is very good, is most effective, but its taste is horrible, so children don't like it. So the other thing is Zithromax. You can use azithromycin. Azithromycin is a nice, like 5 days, it's over. The other medication is clarithromycin. That is also a good medication for ear infection. These are all macrolides. So macrolides, they are good medications in penicillin allergy patients. But what about the duration? Duration, you can mostly, in children, you can follow a 10-day course of an oral antimicrobial agent for the treatment of ear infection. So give for 10 days in children, like who are looking like sick. But patients who are not looking that sick, and if you see if they are having only mild ear infection, you can give like 7 days. Or at least like 5 days. So 5 to 7 days in mild sickness, or 10 days for severely sick. So those are the things you need to remember when you treat these patients, because the microorganisms, they play the key role in the medication you choose. It all depends on what could be causing this. The other thing is, as I said, middle ear effusion. It may stay there for weeks or even months. So when there is middle ear effusion, many times even after using an antibiotic, it becomes sterile, and the fluid will be there. It can cause conductive hearing loss in children. And it can also cause you to prescribe more antibiotics in the belief that the ear infection never left the patient, or the ear infection came back. And you go on writing script after script, but that's not the cause for the fever, because the fluid is only the effusion that has been there from a previous infection. So always remember, folks, middle ear effusion stays there for weeks or even months. If you forget that point, you do a lot of mistakes and you prescribe unnecessary antibiotics to patients, causing so much wastage in terms of money, in terms of effort. And as I said, when you choose the antibiotic like amoxicillin or augmentin, amoxicillin clavulant, you increase the dose. Think of that, you can go up to 3 grams a day. And if they are adolescents, like above 15 or 16 years old, you can go like 1 or 2 grams in the morning, 1 or 2 grams in the evening. So you are using a high dose because you want to reach those strains. And you can go for other medications like cephalosporins when these basic antibiotics do not help. But remember about what is the side effect, like basic things like ceftin, for example, horrible taste. I don't like it. So obviously a kid may not like it. He's not going to like it. So you're going to give ceftin to a little boy or little girl. Think about, they are not going to like it, because those are the things that play a key role. After all, you cannot treat somebody who is not taking the medication. So let me recap and I will finish. Treatment of ear infections. We need to give analgesics like Aralgon, Tylenol, ibuprofen, an antibiotic, observe 48 to 72 hours for worsening or persistent symptoms. And then always go for the basic antibiotics. As I said, don't use topical benzocaine in children younger than 2 years because of the risk of methemoglobinemia. And you don't use decongestants, antihistamines. Don't use cold and cough medications in children younger than 2 years. And for children younger than 6 months, give an antibiotic. From 6 months to 2 years, if they are not sick, observe if they are sick, and if you are definitely sure of ear infection, use an antibiotic. For more than 2 years, same thing. If they look not sick, no fever, nothing, they are looking fine, observe. If they are sick and you are certain of the diagnosis of ear infection, use an antibiotic. So antibiotic versus observation. It depends on the patient's clinical condition and the age. Now, I also talked about macrolides. In patients with penicillin allergy, go for cephalosporins if they have only non-type 1 anaphylactic reactions. Sorry, non-type 1 allergic reactions. And then go for other medicines like cefdinir, cefuroxime, and I talked about intramuscular rocephin. Ceftriaxone like 50 milligrams per kilogram. And I talked about duration, like 10 days at least for the children. So those are the most important things you need to remember. And remember these points, because if you are a primary care doctor or pediatrician or an ENT doctor, you are going to see these patients every day of your clinical practice. I see these patients every day. That's why I am stressing these points so much. So that's about ear infections, folks. Thank you very much for tuning to our today's lecture, and follow us at our website. You can also follow us on Twitter and Facebook. But my website is www.drpaul.org. Thank you very much. Have a nice day.
Thanks for listening. For more medical videos, please visit us at www.drpaul.org and take time to browse through hundreds of health videos we regularly post on our site. If you are preparing for USMLE, PLAB, and other medical exams, make sure you visit our website to browse through our videos explaining the essential points you need to know before taking these examinations. For more information, visit us at www.drpaul.org. Thank you, and may God richly bless you.